Intravenous therapy interventions. To get started, make sure that you always cross-check the solution with the order or the medication administration record and follow those medication administration rights. Inspect the solution container to determine if it's free of floating particles. Make sure it's not discolored, it's not expired, and the container is not cracked or leaking. Prepare a solution container label with the client's name, identification number, room number, date and time the solution is hung, and the nurse's name or initials. And the facility may require additional information, so be familiar with your facility's protocol. Open the administration set and close the roller clamp. That should always be the first thing you do. Inspect the tubing for integrity. If the solution container is a rigid or a glass container, the administration set must have a vent. Apply a label to the tubing as to when it was initiated or when it is to be changed. Remove the protective cap from the solution container spike port and the protective cap from the administration set spike. Carefully insert that spike into the solution container port, being careful not to contaminate the spike or the port. Those must remain sterile. Prime the administration tubing to remove all the air. The roller clamp should already be closed. Squeeze that drip chamber until it's about half full. Hold the distal end of the administration set over a trash can or a sink and then slowly open the roller clamp to allow fluid to flow from the drip chamber through the tubing. It may be necessary to turn those infusion ports or filters that may be built into the tubing upside down to adequately remove the air from those sites. And you shouldn't have to remove the cap from the distal end of the tubing. That site also has to remain sterile, but occasionally you may need to loosen it a little bit to allow the fluid to flow freely. Check the tubing for air bubbles and then remove as needed by tapping on the tubing. Prepare any secondary tubing that's necessary by following the steps provided with the primary administration set, and prime it the same way as the primary tubing, or you can back prime by connecting the secondary tubing to the upper Y port of the primary tubing. So connect the secondary tubing to your solution container. Of course, the roller clamp is closed. Connect the distal end to the upper port of the primary tubing, and then you lower the secondary solution container below the primary bag, and gravity is going to allow that solution from the primary bag to flow through the secondary tubing up to the drip chamber. So when the drip chamber of the secondary tubing is about half full, close that roller clamp on the secondary tubing, and now you're ready to go. This is recommended when you have a solution container that only has 25-50 mLs in it, so you're not wasting medication by accidentally running too much through the tubing. Make sure that you determine the compatibility of secondary IV fluid or medication with the primary fluid. That primary solution container, when you're infusing a piggyback, has to be lower than the secondary solution. Extension sets can be used for continuous or intermittent infusion sets, and they help reduce the manipulation of the catheter inside the vein, so they are recommended. A needleless hub will be attached to the other end of the tubing. The extension set is flushed to remove air prior to attaching it to the catheter. A blood sample can be drawn, and intermittent infusions or other routine normal saline flushes can also be done through that extension tubing. With normal saline flushes, make sure that you are applying positive pressure while closing that slide clamp to help prevent reflux of the blood into the catheter and/or the tubing. The extension tubing does not require changing when the administration sets or secondary tubings are changed, and that helps prevent manipulation of the catheter in the vein also. So, client preparation. We need to provide teaching. What is the purpose of the therapy? The possible length of the therapy? Are there any restrictions? We need to encourage the client to keep the site dry and don't play with the flow regulator. The client should know when to contact the nurse with IV therapy. For example, when the dressing begins to feel wet, pain develops, swelling develops, or blood backs up into the administration set tubing. Assess the client for IV site suitability and select the most appropriate site for the client and the solution that's going to be infused, and ensure privacy per the client's wishes. When you're selecting that site, national standards indicate selection of the least invasive device with the smallest diameter and fewest number of lumens should be used. We may need to use light devices, infrared light devices, or ultrasound to locate veins. And when we're considering site selection, think about the type of therapy that's prescribed, the length of time the therapy will be used, the client's age, their current medical diagnosis or comorbidities, their history of vascular access and vascular anatomy, and their care setting and staff availability and ability. So base the site selection on their age, diagnosis, physical and vascular condition, previous IV therapy, and the length and type of therapy to be administered. Those are important things to remember. So attempt to choose a vein that's soft and bouncy when you palpate it in the non-dominant arm. If you try a site and you're unsuccessful, you need to go above that site to try subsequent infusions. So in other words, always choose the distal veins first. Avoid areas of flexion, areas that are painful to palpation, bruised areas, red swollen areas, veins that are hard and sclerosed, veins near a site of an infiltration, phlebitis, thrombosis, or cellulitis, veins in an arm that has an arteriovenous fistula, for example, those clients that are on dialysis, veins that are on the site of an axillary node dissection from breast surgery, such as a mastectomy, if they have lymphedema in that arm, or an arm that's been affected by a stroke, avoid those. Avoid veins that are near an area of trauma, such as burns or scarring. Avoid the veins on the inner wrist because there's a possibility of nerve damage. And avoid areas that you are able to see valves. They'll look like an intermittent bulge when the tourniquet is applied. So always try the hand and the forearm first. And again, choose those distal veins first. For vesicant or irritating drugs, use the cephalic and basilic veins below the antecubital fossa. Remember, veins in the leg or foot or only used as a last resort in clients that are adults or ambulatory because there's an increased risk of deep vein thrombosis. If those veins are necessary, you have to contact the healthcare provider first. So, in selecting the device, usually, once again, shortest length, smallest diameter, fewest lumens, and least invasive. A 20, 22, or 24 gauge is adequate for most infusions, including blood and blood components. A 16 or 18 gauge would be used for most surgical procedures, rapid fluid administration, or life-threatening situations. But realize that pediatric and older adults may require smaller catheters. Clip excessive hair. We don't want to shave it because there's a risk of microabrasions, and that will increase the risk of infection. Cleanse the site using an antimicrobial agent. The specific agent will be determined by the facility's protocol. However, chlorhexidine is the cleanser of choice. Cleanse the site about the size of a dressing that will be used, and cleanse it for at least 30 seconds with a scrubbing action. And always allow that site to dry naturally to help prevent chemical burns. Remember, only one venous access device shall be used per attempt. Different vascular access requires careful assessment and collaboration. Difficult access device. Let me just repeat that. Difficult vascular access requires careful assessment, and you may need to collaborate with your coworkers. Vascular distension can be obtained from tourniquets, gravity positioning, warm, dry heat from a warm blanket or towel, hand pumping, or lightly stroking the vein, especially with an alcohol prep. Non-sterile, one-time use disposable gloves should also be used. And remember, don't palpate that IV insertion site after you cleanse the skin unless you're wearing sterile gloves. So to perform venipuncture, once again, review the orders, perform hand hygiene, gather and prepare the necessary equipment, identify your client, assess them, and provide education. Select a site and vein. Dilate that vein by using a tourniquet or blood pressure cuff about 6 to 8 inches above the selected site, and don't leave it in place more than 4 to 6 minutes or 1 minute if you're using blood collection or doing blood collection. Apply it as loosely as possible or avoid it in clients that have compromised circulation, fragile veins, or they may be at a risk for bleeding, such as hypertension. You may just need to use a coworker's hand to apply pressure to help distend the vein in these clients. You can also aid in vein dilation by lowering the arm to a dependent position, using the dry heat, sometimes multiple tourniquets in clients that have extra adipose tissue. Use a tourniquet at least 1 to 2 inches wide. Have the client open and close their fist and lightly rub the vein downward. Determine the need for a local anesthetic. Facility policy must allow for administration of a local anesthetic if you're going to use one. It should be the least invasive and pose the least amount of risk. We can use intradermal lidocaine, and that would require 0.1 mL of lidocaine, 1% without epinephrine. It's effective within 20 to 30 seconds. It does require an order. The needle would be inserted at a 15 to 25 degree angle, and you administer it next to the vein or on top of the vein if the vein is really deep. Always aspirate for a blood return because we do not want to inject that lidocaine into the vein. And when you inject, you should try to obtain a small wheal. Topical transdermal agents are really a good choice for children or clients that are unable to tolerate needle sticks. However, it does require 30 to 60 minutes to be effective. So, you have to consider how quickly do I need this IV access. And follow your manufacturer's directions. Sometimes you need to cover that site while that anesthetic is in place. There's also topical vapocoolant sprays and pressure accelerated lidocaine that delivers dermal analgesia in 7 to 10 minutes using a mild electric current to deliver the analgesia. So once again, prepare that site. Clip the hair if necessary. We don't want to shave it. Wash it if it's visibly soiled. Perform your hand hygiene and put on your clean gloves. And then cleanse the skin with the antiseptic 2 to 3 inches around the site. And then don't touch it. Chlorhexidine is the preferred solution. Scrub back and forth for at least 30 seconds and allow it to dry. We can use 70% isopropyl alcohol or povidone iodine if chlorhexidine or alcohol is contraindicated, but it has to stay on the skin for 1.5 to 2 minutes. Stabilize the skin by stretching the vein or stretching the skin below the intended site with your non-dominant hand. So to insert, national standard of care for a nurse is to make no more than 2 insertion attempts. Inspect that catheter for integrity. Do not withdraw and then reinsert the stylus because there's a risk of damaging the catheter. Insert steady and direct. Try and use one motion through the skin and into the vein, or steady and indirect, where you go through the skin in one motion and then into the vein with the second motion. Observe for blood in the flashback chamber of the catheter. Hold the stylet in place and use the finger to advance the catheter to the hub. Apply digital pressure above the insertion site and hold that hub in place while you retract the stylet. Quickly attach the administration set or extension tubing to the catheter hub. And if the catheter does not want to advance into the vein, we sometimes can float the catheter in by attaching the administration set or extension tubing and then infusing those IV solutions or normal saline. Gently flush the catheter with normal saline and observe the vein. If swelling is noted approximately where the tip of the catheter is in the vein, then the vein is not cannulated and we have to do this all over again. If no swelling is noted or the nurse observes the saline traveling up the vein, cannulation was successful. Then secure the catheter using a stabilization device if possible, a transparent dressing, or sterile tape. It should never interfere with assessment and monitoring of the insertion site. A commercialized vascular access stabilization device should be the preferred method of stabilizing that catheter. It improves dwell time and reduces overall complications. Excuse me. If tape is used, make sure that you do not encircle it with the arm or the extremity with tape because that can provide a tourniquet effect. If sutures were used to secure a device and they become loose or they're no longer intact, they need to be removed. Apply a sterile dressing with a transparent dressing or gauze with tape. Don't cover the catheter hub with a transparent dressing. Transparent dressings are changed every 5 to 7 days. Gauze dressings are changed every 48 hours. If you have a transparent dressing with gauze, that is considered to be a gauze dressing, so it needs to be changed every 48 hours. Dressings are changed otherwise if it's damp, loose, or visibly soiled. Dressings and sites can be further protected by covering with a stretch netting. And then consider joint stabilization. Areas of flexion are avoided when possible for cannulation. If the site is affected by joint motion, apply an arm board, and it should be placed above and below the joint. Then secure it with rolled gauze or tape, but allow the visualization of the IV site. It is not considered to be a restraint. However, it should be padded, and it should not constrict blood flow or impede assessment of the insertion site. Periodically, that device needs to be removed to assess circulation, skin integrity, and range of motion. Frequent skin checks should be done at the pressure point areas of the stabilization devices, and then document the use of the device and removal for assessment and range of motion. Apply a label to the dressing with the date, the gauge of the catheter, and the person who is inserting it, their initials. Check all connections, the flow rate, and dispose of materials appropriately. Remove the gloves and perform hand hygiene. To insert a winged infusion set, make sure that you prime the air from the tubing if it's to be used for infusions, although this device is not recommended because of the high risk of infiltrations. Then you aseptically connect to the adapter of the administration set tubing. Open that clamp and allow fluid to displace the air. Close the clamp. If it's to be used to draw blood, you do not need to remove that air. Pull the skin taut to stabilize the vein. Pinch the wings together and then gently insert the needle into the vein. Make sure the bevel of the needle is up and insert at a 5 to 15 degree angle. Blood return would be seen in an unprimed tubing attached to the hub. And at this point, then you would utilize the same techniques as you would with the over-the-needle catheter. Soft mittens are recommended for client populations such as the pediatric, the elderly, those with cognitive limitations, whenever there's a risk for accidental dislodgement. They are not considered a restraint. Physical immobilization devices to protect the vascular access device site shall not be routinely implemented and shall be avoided whenever possible. However, they can be used if necessary, and that would be like a wrist restraint. Frequent assessment of the skin and the site does need to be done when these devices are implemented. So to maintain a site, again, chlorhexidine is the cleanser of choice for the skin and IV connections, although 70% isopropyl alcohol is acceptable. Remember that regular ongoing assessment needs to be completed, and assess your sites at least every 4 hours. But it's more frequent if you have a pediatric client, which is done at least hourly, a critically ill client, clients receiving sedatives that have cognitive alterations, clients with infusion sites at joint flexion areas. Those should all be done hourly. Clients that are receiving vesicants in peripheral sites need to be assessed at least every 5 to 10 minutes. The assessment will involve assessing for the correct fluid, the flow rate, the volume, the expiration date of solutions, dressings and administration sets, dressing integrity, the site, and client complaints. So routine flushing of a saline lock or intermittent device. We use 2 to 5 mLs of normal saline for a peripheral line and 10 to 20 mLs for a central line. We flush before and after medication administration, between multiple medication administrations, and per facility for routine flushings. And again, that's usually every 12 hours. It maintains patency, but it does not prevent blood clots. To change a peripheral dressing, we do that every 5 to 7 days if it's transparent, or every 2 days if we use gauze. So gather your supplies, perform hand hygiene, explain the procedure to the client, put your gloves on, assess your site, then remove the dressing and any stabilization devices, being very careful not to dislodge that catheter. Excuse me. Cleanse the skin with antiseptic solution. Apply a new stabilization device and dressing, and discard your supplies. Remove the gloves and perform hand hygiene, and make sure that you label the new dressing. Central line dressing changes are going to be every 5 to 7 days if it's a transparent dressing, or every 2 days if a gauze dressing is used. Change the dressings are going to be basically the same procedure as a peripheral dressing change, except the nurse and the client must wear a mask to prevent the introduction of pathogens. Remember that IV site is much closer to the heart. There are much larger blood vessels. Very important to wear sterile gloves and wear a mask. Change solutions every 24 hours or per facility protocol. With fat emulsions, parenteral nutrition, and blood products, those may need to be changed more frequently. Change your solution and administration set at the same time whenever possible to help minimize manipulation of the system. Changing the administration set will be according to your facility protocol. Otherwise, if they don't have protocol, change it every 96 hours for routine IV solutions, every 24 for parenteral nutrition. Fat emulsions are going to be every 24 and every 4 hours, or with every unit of blood component. Change it if there's a different type of solution being used, if contamination is suspected, if the system has been compromised, if you're inserting a new vascular device, if a secondary set has been disconnected from the primary administration set after intermittent usage, we would change that tubing every 24 hours. With intermittent usage of the administration set every 24. Lipid infusions are going to be changed every 12 hours. So going back to what I previously said about fat emulsions, I apologize. Those are lipids. They need to be changed every 12 hours. Blood and blood components would be changed after every unit or every 4 hours, and intermittent infusions, make sure that you're putting a new cap on the end of the tubing after every use. Changing that IV catheter, we don't routinely change them depending on the dwell time. So for example, it used to be, excuse me, you had to change an IV insertion site if it had been in place for 3 days. Now, the rule of thumb is we look at the condition of the catheter. That's going to direct us when to remove it. So is there a sign or symptom of a problem or any complication? Is there any tenderness or pain with or without palpation? Is there redness or blanching to the site? Is there heat or coolness to the site? Is there swelling when compared to the other extremity? Is there hardness on palpation, fluid leakage or purulent exudate, abnormal functioning of the IV site? Always document your assessment and any dressing, administration set, or solution changes. Getting blood from a peripheral catheter. Realize that LPNs cannot obtain a blood sample from a central venous access device unless you're in the state of Missouri. Kansas LPNs cannot do this. You're going to use a slow, gentle aspiration using a 3 to 5 ml syringe. You may need to put a tourniquet above the site if you're just doing blood sampling and you're not obtaining it from an IV catheter. You would withdraw 1 to 2 mLs and discard that if it's an IV catheter. Withdraw the necessary amount of blood for the test. Flush the catheter and extension tubing. Make sure that you properly label your blood tubes. And if there's a continuous infusion before you obtain a blood sample, hold that infusion at least 2 minutes. To terminate IV therapy, national infusion standards, once again, do not recommend discontinuing a device based only on the amount of the time the catheter has been in place. Nursing assessments can indicate the need to discontinue the site, and it does not require a physician's order to discontinue a site. It requires a physician's order to discontinue therapy. So if a site was obtained under suboptimal aseptic conditions, in other words, it was done in an emergency situation and the asepsis was questionable, we need to remove and replace that site within 24 to 48 hours. If the assessment shows signs of infiltration or extravasation, if the site is red, tender, indurated, or warm to touch, if there's evidence of thrombophlebitis, if the site is infected and we have drainage that indicates potential infection, if the cannula is occluded, evidence of cellulitis, we suspect an IV-related sepsis, there is a product defect, the client complains of pain at the site, and make sure that you always document the reason you're discontinuing that site and the assessment of the site. So to discontinue, hand hygiene, put your gloves on, provide client education, discontinue any infusions or clamp the extension tubing, remove the dressing, stabilization device and tape, inspect the site, cover the site with gauze or a cotton ball and slowly remove the catheter parallel to the skin. Slowly remove the catheter, not quickly. Apply pressure until hemostasis is achieved. Then cover the site with gauze and tape and inspect the catheter for integrity and then document all of your interventions.